Okay, so I see we have some people starting, and again, just in the interest of time, I would like to welcome everyone to this month's CCSRC rounds. I am Athena, and I will be the moderator for today's session, so thank you all for joining us. Today we'll hear from our speaker, after which we will open up the floor for discussion and any questions that you might have. And I would like to introduce Dr. Christopher Longo, who will be presenting on financial toxicity in cancer, quantitative and qualitative examinations. And Dr. Longo has over 30 years experience in clinical research, economic evaluation, and access strategies for pharmaceuticals. He has published clinical, economic, and policy research in a number of therapeutic areas, including cancer, diabetes, sepsis, and mental health disorders. He teaches courses in health economics and population health at McMaster and has taught a 5-week module on health economics and public health at the Dalai Lama School of Public Health at University of Toronto. And we are delighted that Dr. Longo could be with us here today. And without further ado, I would like to hand it off to you, Dr. Longo. Thank you.
Thank you very much for the introduction. So I don't have a lot of slides here, so I actually have some leisure ability to sort of meander through my slide deck, if you like. I did give a talk on one portion of this before, I believe, to this same audience, so some of you may have heard it, but it's only about 3 of the 20 or so slides that I'm going to talk about today. So this is just about my background. Just recently became a full professor in the department, member of the Center for Health Economics and Policy Analysis, and co-program lead for the Health Technology Assessment for ARC. Just some of my many roles. So what I'm really hoping to do here is highlight, firstly, the growing interest in financial toxicity, and then share the evolution of thinking around some of the terms used to capture this information. And then I'm going to look at some research. So the cross-Canada study that I mentioned before, the quantitative and qualitative data. So I've certainly presented the quantitative data before, but the qualitative data I haven't presented, at least not in this venue. Then talk about some quantitative literature reviews, work that we did, some qualitative literature review, and then a more recent publication called Unequal Distribution of Financial Toxicity, which gets into a different dimension of the whole discussion around financial toxicity. So just to get a sense of things, we did some systematic reviews recently, and we discovered that in the period of 2005 to 2009, there were 128 papers that were published, and that was using, Medline and Embase and Cochrane and those sorts of databases all lumped together. I think I included Econlit in that as well. And you can see in that 2005 to 2009 period, there were 128 papers. And then for 2010 to 2014, there were 205 papers. And then for 2015 to March of 2019, which is not even quite 5 years, 415 papers. So there's clearly a growing interest in this area. And in fact, COVID, if anything, has made it a little worse because of the lockdowns and people losing jobs and those sorts of things during the COVID period in, all over the world, really. We've seen an even more explosive number of articles in this space that go beyond this. So clearly a growing interest in this area, and very much linked to the impact on healthcare budgets. So as governments have less money to spend, they trim around the edges a little bit, and sometimes what that means to patients is things that were covered are no longer covered, and so they're making more and more decisions. There also is an increased breadth of the investigation. So, initially when we were doing this kind of work, and I've been doing this work since, I guess, the early 2000s, it was really focused on the out-of-pocket costs and the lost income. We're starting to see more literature on foregone care. So people who have a financial situation where they have to make decisions to reduce their care or decisions not to get the care at all. The increases in stress and strain and distress, which I'll define in a slide from now. And then more recently, a lot of looks at different population differences and how these problems are even more problematic in these populations. So, And lastly, we'll talk about it later, but some of the strategies that people have started to develop, particularly in the US, to try to mitigate some of these issues. So here's some definitions just for those, and this is just a page right here. I don't know if you can see my mouse. Can you see my mouse moving around or no? Anybody?
Yeah, you can see it. Yeah.
Okay, good. This is actually from the paper we did looking at some of these papers and the publication. So this is a summary of it, but in essence, toxicity, by the definition we're using for financial toxicity, is distress and hardship arising from the financial burden of a cancer treatment. Stress, the definition is the impact of the cancer diagnosis on the ability of the household to make ends meet, more of an objective measure, and then strain and impact on an individual or household and how they felt about the financial situation they were in, more as a subjective measure. And then finally, distress, closely linked to financial toxicity, but represents the psychological response they have to it. So there's a list here of different studies in Ireland, in Australia, in France, a couple more here in Ireland and in Denmark, where they've done these studies looking at stress and strain and distress as well. So these sorts of investigations are looking much more common these days than they were a few years ago. So I did a national study. I should say I did a national study because, of course, I had about 15 investigators involved. So I was leading that group, but clearly there were a number of people involved in the work for this. So it's a national study that enrolled about 900 patients. And subsequent to that, there were another 220 patients that were enrolled in Quebec from a separate researcher who approached me, who wanted to use the same questionnaire, but do it in the Quebec setting. So now that would be 1,100. I have not yet combined that data. It's been sitting on my to-do list for about 18 months now. So I'm a little slow to get to that. The initial study of 900 patients has about, well, a little over 300 breast cancer, just a little under 200 colorectal, about 1.5 for lung, and a little over 200 for prostate. What we found from that study was the mean cost per person per month was about $518, just out-of-pocket costs, another $179 for travel, and about $85 for parking. And when we started breaking it down in terms of their stress level, so if they described themselves as having a high burden, that number went up to about 961. We also found that about 30% of the sample took time off work, averaging about 18 days. And then about 26% of caregivers took time off work, averaging about 11 days. And then 41% of the sample had to make decisions to reduce their spending. And that number rises to 52% if they're earning less than $50,000 as a family income. So this is a bit of a snapshot of where. So I initially did this work for my PhD back in 2001 to 2003. And this area over here is the data we got from Ontario. And you can see here, the travel cost was about $400, parking about $50, total out-of-pocket costs about $200. And so that adds up to about $646 per month, plus the lost income, which came up to about 11. Now, if you want to do a straight comparison, and you go over to the Ontario column, you'll see that the out-of-pocket cost, I didn't line these up quite right. So the out-of-pocket cost was $213, now it's $461. The parking was $47, now it's $103. So this is a 15-year time period. Interestingly, imputed travel costs went down. Now, if there's one silver lining in this analysis, is that in 2001 to 2003, we essentially had 5 cancer centers in Ontario. By the time I did this study, there were a number of satellite centers that had opened up, and that number was 18 or more, if you include some of the smaller satellites that were available, which meant people didn't have to travel as far. So if we've done anything well here, we've basically been able to move around those services into some of the remote regions to minimize the impact on people's travel. So that's a piece of good news. So that total came to 758, which is just a little bit more than it was back in 2003. But if you start looking at the lost income, this is where there's a big change. And part of that is, in my opinion, because this is quantitative, not qualitative, would be probably nice to get a better sense of this, is that as the system itself provides fewer supports, people are finding themselves having to take the time off work, particularly for the caregivers. So big increase in the amount for the caregivers, an increase as well for the patients, but probably the biggest increase was in the caregivers taking a bigger share of that burden. And so when you look at the totals for Ontario, it went from about $1,200 a month to almost $3,000 a month. You can imagine this puts a lot more people at risk of it being a financial burden or a financial toxicity. You can see in the national study overall, it was about 25, with some differences across tumor types. And of course, I have analyses across provinces as well, but I can save that for discussions if people want to ask about those sorts of things. So in addition, when we did that work, we had an open text field at the end. And Dr. Marg Fitch, who was working on the team, had agreed to do a content analysis of those 378 respondents who had generated 700 comments. And her observations, so these are really her observations, 21% lived alone, 60% were female, 67% were 55 years and older. Those are the ones who made the comments. They all experienced costs related to cancer. That's not a big surprise to anyone. Many experienced a reduction in income. Again, that shouldn't be a big surprise. Not all experienced distress related to dealing with the financial challenges, and some were able to manage. As you can probably imagine, that was very much across differences. There were differences across SES. So those who are in the lower income, lower SES had more difficulty coping with some of those challenges, and maybe had less flexibility to cope with those challenges. 40% reported emotional distress related to the financial challenges they were experiencing. So this is just one quote from a patient. You are dealing with the cancer, and then on top of this, and then this on top of it. And I think that sort of sentiment has been repeated over and over again in some of the qualitative work we've looked at, that, you know, they already have reduced capacity to deal with any kinds of shocks to their routine, whether it's financial or otherwise. So dealing with the cancer, and on top of this, dealing with financial toxicity was sometimes just almost unmanageable for them. In fact, in our quantification of their level of burden, the last category was an unmanageable burden. And we did find about 20% who clicked that box for unmanageable burden. So what else did we see in the qualitative work? We found that a lot of the costs incurred or burden incurred were related to lost work. They were related to transportation. They were related to issues around coverage, and they were related to trying to have the right foods or adjust their diet based on their cancer diagnosis and what was recommended, either by a healthcare practitioner or perhaps a nutritionist. Well, I guess that's still a healthcare practitioner. Reduced income and reserves, 30%, 37% of those making 50K or more, and 18% of making 30K or more. It may very well be part of the reason for those numbers being lower in the under 30K is the fact that many of them just weren't working. And so they didn't have a reduced income because they weren't working, or they were on unemployment or some such thing. Reduced work productivity, reduced work and or work productivity was seen in a number of patients as well. What did they do in terms of compensated? Some of them had to prioritize their spending, postpone plans or activities. And of course, their responses were often increased anxiety, worry, anger, frustration, and fear about the future and the uncertainty of it. Different strategies have been used by people. I mean, some people did things like even talk to a financial analyst or specialist to see if there were ways they could manage their funding, their disease. Sometimes people, of course, if they were lucky enough and they had reserves, they would access some of those reserves. You know, unfortunately, sometimes things like their kids' university funds or their retirement funds. The one thing that was noted as well that I think is interesting is they found it difficult finding help. So quite often people comment, no one mentioned that none of the healthcare professionals mentioned that there were other strategies that could be used. I think this is quite variable, to be honest. I think there's some cases where centers have done an excellent job making people aware of this. But I think some of the challenges with this, from my experience, are patients are often asked this at the very beginning of their treatment, and they think they've got it under control. They're not imagining the kinds of expenses that they actually end up incurring. And then 3 months later or 4 months later, they're in trouble and they're not asked again. And so if I had any message to deliver to the healthcare professionals out there was, check in with them every few months to see, some of them really, really underestimate just what the financial implications of this diagnosis are. So these are just some quotes from individuals. I can pause here, or I could read them. I guess I'll read them. I am very fortunate to work for a company that allows me to be off for up to 9 months with 100% pay. All prescription drugs have been covered by my health plan. I know I am one of the very fortunate few. And I think, we did try to survey everyone. We didn't deliberately say to people who have financial challenges, please fill out this survey. We wanted to see how different it looked across populations. My career has been completely put on hold. My caregiver is also my business partner, and we are both self-employed. So from a financial standpoint, it has been a disaster. We have spent our entire life savings to keep our house while I have been sick. And, the self-employed piece, it shows up in some of the other literature as well, that people on self-employment are really, really hit hard. They don't seem to have the support networks that you could get from an employer, particularly like a Fortune 500 employer, where there are wraparound services available to them. Self-employed, unless they've purchased care, then they're really, really feeling the burden. My cancer diagnosis has had a devastating impact on my income and ability to meet my financial obligations, particularly since my spouse is ill as well and quit to take care of me and himself. So again, this has everything to do with people having an income stream and having the income stream disrupted. I've been living off my credit card a great deal because of no savings due to $15 an hour wages and no employment benefits. So again, this is an example of someone who's in the lower socioeconomic status. And so again, hit very, very hard. And finally, because of the cost of cancer, canceled family trips, canceled home renovations, lost complete income, long-term insurance denied. This is another thing we see a lot of, is that people have their insurance connected with their employer, or they think they have coverage and they find out they don't. So those are just a few examples. So we did a couple of literature searches, and this was actually before we did our study, our 2016 to 19 study, and we divided into two pieces. We did the quantitative and the qualitative. So this was our this is our quantitative one, and this is published. I'll show the references at the end. So we did a search from 2005 to 2019, so about 15 years. We were partway through the year, looking at developed countries with very high development index. And we did that because we wanted to look at countries that were comparable to Canada. To be honest, my strategy was to have a landscape under which to discuss my own work, which was at that point in progress. We excluded the US because there are plenty of studies in the US space, systematic reviews looking at this. And of course, the problem in the US is much worse. But also there's, less of a public funding. There's a public funding in the US system, but it isn't the dominant funding source, the private is. And so we really thought US is a little bit of a different animal. So we really wanted to look at developed countries where it was predominantly a publicly funded system. So we ended up with studies from Canada, Australia, Ireland, the UK, Germany, Denmark, Malaysia, Finland, France, South Korea, and the Netherlands. There's quite a bit of range here in the reported monthly out-of-pocket costs. Some as low as $17. And obviously this has a lot to do with how good the wraparound services are in these countries. Lost income, the range wasn't quite as low, but again, some countries do have programs where there is a income compensation for people who have cancer, or any kind of serious health illness. And then 14 studies reported travel accommodation costs, again, that varied between $8 and $3.93, again, somewhat dependent on the level of support within those countries. 6 studies reported stress. This variability is not that large, so the stress factor is pretty clear across these developed countries. Strain, again, depending on the support that's available in the countries, maybe a little less so for some countries than others. And distress or toxicity between 22 and 27%. That's pretty close to the numbers that we're seeing now. We're actually edging up closer to 30, which is very different from the number. If I look at those people who reported high or unmanageable burden from the Ontario study, it was down around 19%, and now it's up over 30. So as we see an increase in the costs of care and some, withdraw of services as governments try to manage their budget, the percentage of people who are falling into the high distress or the high toxicity is actually increasing. So as I've noticed in this last point, all suggesting that government-funded programs still result in gaps for a significant portion of the population. And that's not just true in Canada, it's true in a lot of these other countries that are listed here. So on the qualitative side, we did the same, on the same extraction, we just separated out those qualitative papers that were identified to understand how patients and families experience, respond to, and cope with those burdens. So again, same time frame, January 2005 to March of 2019, selected all the qualitative design and focused on the results. 12 articles based on 10 studies, so a couple of them published more than one. 2 in Canada, 2 in Australia, 3 in Ireland, and 3 in England. Taken as a whole, these articles illustrate the complexity and multifaceted nature of experienced financial hardship following a cancer diagnosis. This was something that Mark Fitch had created to talk about all of the stresses and all the factors that play into this. And I'm going to lean forward a little bit because of my bad vision. On this side, you have the government policy impact. On this side, you have the healthcare, cancer center strategies. From here, you have the employer strategies, and here you have the individual strategies. And as you can imagine, there's a fair bit of variability here at the cancer centers. Some of the larger ones providing very strong wraparound services, some of the smaller ones not as much. And of course, the employer will depend on the employment type that they have, if they're with a large employer with full coverage or a smaller employer with no coverage. And then we have some policies that vary, as we've already talked about, by country, in our case, even by province. I think this is a nice way to sort of visually look at it in terms of sort of some of the outcomes that come from this. You have an emotional, spiritual, and physical well-being, but, working against that is reduced income, reduced social and leisure time, increased costs, increased family burden. All of these things are having a net negative impact on people's well-being, their stress, their distress, their anxiety, all those sorts of things. And then, I guess my last conversation is what's been happening lately. So I was asked to write a paper on sort of, what is going on in this space recently. So this paper was just published in 2020 or 2021. I think it's 2020. And we really wanted to look at, and this is just a front page of the actual abstract, but I'll turn to the next slide where I go into a bit of detail about what we found in our rapid review. So one of the things that came out of that was receiving immunotherapies and having metastatic disease to increase financial risk. There isn't a lot of data yet about immunotherapies, but I'm sure you're all aware that these drugs are significantly more expensive, often between $5,000 and $10,000 a month. And if you're lucky to live in a place where the government fully covers that, then you're great. But if you're living in a place where it's not covered, or if take the US example, where you have an insurance with a 20% copay, a 20% copay for a $10,000 drug is still $2,000 a month. And there are a lot of people who are trouble managing that, either making a decision not to get it at all or foregoing something else. So the foregone care, financial distress we talked about, often related to one or more of price of care, geographic limits, insurance coverage, and insufficient savings. The insurance coverage really shows up in the US data. Obviously, I had the opportunity to go to a conference in the US in Phoenix just before the pandemic. I think it was October of 2019. And I was presenting on the early results from my own work. And I think there were 35 publications that were presented either as posters or as presentations at that conference. And what was really interesting talking to some of the individuals there is that the people in the lower socioeconomic status tend to have insurance plans. If they have them, they're very poor plans. They have caps, they have copays of 30%. And so these people are really, really suffering. We are in a good position, relatively speaking, to the US, but there are still some issues. So again, all of this translates into distress and decisions to forego care, and those things emerged over and over again in the work that we found in this rapid review. The role of racial and ethnic origin, and I think we know these things. I think, this is a fairly common piece of literature about income and race, maybe a little less known about the young, which has more to do with the amount of savings they have, lower education. I think that literature showed up, and of course the underinsured. All of these individuals, these groups show higher rates of work loss and higher distress associated with their cancer diagnosis and managing the financial elements of it. Emerging focus on screening programs and policy changes. So particularly in the US, there were a number of papers that showed up that looked at trying to find or develop screening tools that would identify the people that were at high risk for having financial toxicity or, likely to, forego care. And they're screening tools that would allow them to sort of focus in on either helping them with coping strategy, helping them with financial literacy, or providing some wraparound services if they're available. Again, in many cases, there aren't necessarily significant wraparound services in the US. And also advocacy with governments on mandates related to insurance coverage. This has been an ongoing issue in the US. So again, most of these were US-based studies. There were a number of studies that talked about COVID and how it had really exacerbated some of these problems, increasing the incidence of financial toxicity and distress, mostly for those in low income. Often those people are the ones that would lose their job or were not unable to work because of COVID. And so low income, low education, racialized groups were definitely the ones who were affected. There were 2 or 3 papers on this, and that was done a year ago now. So there's probably a year and a half ago now. There's probably even more papers out there now looking at this. Where's the research going? What it's looking like in the future? There seems to be more work on decision to forego care. In a way, when I started this work, I took a snapshot of what people were experiencing, but we weren't following people up to see what implications that had on their overall health. We're seeing more and more of those studies now, where we're seeing decisions to forego care. And there are other studies that are out there, of course, that show that link between decisions to forego care and poorer outcomes. So more and more of that literature is showing up that's suggesting that the price of cancer treatment, a big piece of that, of course, is going to be the cost of the newer strategies, the newer pharmaceuticals. Means more and more people are having to make these kinds of decisions to forego care and in order to manage their financial situation. So I think I'm pretty early a little bit. It's only about 1:30 now. So just to quickly summarize, there's a growing interest in the financial toxicity or burden of patients and their caregivers and recognition of an impact on all aspects of living. I do want to highlight that point about caregivers. We are measuring caregiver burden because cancer is a disease that very much involves caregivers, sometimes multiple caregivers. In fact, in our study, the national study that we did, we found that on average, people had 2 caregivers, 2 primary caregivers, and in some cases they had a third, and that the burden on the second caregiver was almost as large as the burden on the first caregiver. So in terms of lost time, and I think what's actually happening is people are sharing that rather than it being on one person, they're sort of dividing the time. And this is part of the reason why the impact on caregivers is really not trivial. If it takes, sometimes it's just too much burden for one person. Presented in both in quantitative and qualitative research. More nuanced examinations include the stress, strain, and distress. We're seeing that more in the qualitative space than in the quantitative space. Links to decisions to forego care are becoming more common, unfortunately. Examination of at-risk populations based on SES, race, or geography are increasing. I think, we're all being educated on diversity and inclusion. And I think as we're seeing this, we're seeing more of this sort of evaluations being done. And then the last few years, closer examination, screening programs, and policy changes that may be able to address these gaps. That's not so much a Canadian experience as it is, I'm going to say, predominantly a US experience and to some degree Europe. And then the last thing I have on my slide here is a push or a promotion, if you like, a shameless promotion of a financial toxicity special issue that both Dr. Fitch and myself are co-editors of, that has a submission deadline of the end of this year, December 15th. Actually, we made it 15th so that we didn't have to be reviewing them over the Christmas holidays, but I think we're still going to be reviewing them over the Christmas holidays. So I think with that, I will stop there. I think my next slide is just some references for all of the studies that you can see that it seems to be a two-person show mostly here. Dr. Margaret Fitch, who I'm sure some of you know, and myself. Most of the qualitative work was led by Marg, and the quantitative work was led by myself. So I'll stop there.